There are a couple of gentlemen here who are lying. They had surgery when they were 8 days old. They forgot about it. But everybody, unfortunately, everybody one of these days is going to have something done to him or her. And, you know, we all want to go to, quote, the best, end quote, surgeon. But none of us has any clue as to what good surgery is and what it should be like. And I was delighted to hear the title of tonight's talk, which is, what is good surgery? Which also means, what is bad surgery, and so on, and what to look for. Whether you're having a carpal tunnel done, or cataract, or a heart transplant, basic principles are all the same. Dr. Peter Salinger is the Chief of Surgery at NYPQ. He has put together an amazing surgical department, and I say that because I've had plenty of patients who've been dealt with by them. And he does a pretty good job himself too. But, our biographies are back there. I have to apologize. Linda Spiegel, who is usually here giving out pads and pens, unfortunately had an accident. She won't be able to get here. But we wish her a refuah shlema. With no further ado, there is a D in his name, Dr. Peter Salinger.
Thank you. Where should I stand? Can I stand right here?
Any way you want. Just so I can see you in the
Do I need the microphone or can you hear me?
Use the microphone. Always use the microphone.
You always use the microphone?
Yeah, just, maybe just stand over a little bit. Just so you just see yourself with a selfie. Just think selfie.
Yeah. Thank you very much for having me. When Mel asked me to give a talk, I had to think about what to give a talk on. I've seen what others had done. My specialty is surgery of the liver, pancreas, big cancer surgery, and it's nothing fun to tell you about. But my passion is about outcomes, is about how do we know how we do. So, yes, I'm the chairman of the department and all these titles, but what does it actually mean? What does it mean to be a chairman? What it means is that my first duty is not to do good surgery, but to make sure others do, and to keep patients safe. So, I will talk to you about what good surgery is. This gentleman, Jean-Henri Dunant, was the person who made me want to go into surgery. My first mentor. I went to medical school in Switzerland. I am from Switzerland. And I wanted to be a surgeon because I wanted to be the way he was. Thank God he was a surgeon, not some esoteric other specialty, but the way he connected with patients, the way he talked to them, the way he treated them and talked to colleagues. When he entered a room, something happened. Patients felt better, and I wanted that. And so, as a medical student, I met him as a third-year medical student when we started our clinical work. And he sat us in a room, a group of 5 or 6 medical students, bright-eyed and ready to do all sorts of things. And he asked us, what makes a good surgeon? Now today we know it's a team sport, so we talk about what makes good surgery. And we're all sitting there and we gave him all these answers, and actually that's me here in my graduation class. And you know, attention to detail, technical skills, clinical excellence, clinical aggressiveness, and because at that time surgeons were the cool guys, you know, sports cars. And he looked at us and he said, no, that's not what it is. This is actually a surgical picture that shows a big tumor here. You take out 80% of someone's liver and they live to fight another day, and that's, you know, amazing surgery. But he said something else in French. It's the indication. And we looked at him like, the indication? What does that mean? We want to cut, we want to do things, not indication. Or translating here, we don't want to daven over it, we want to do it. So he said in French, le patient vient avec sa valise et part avec sa valise et non dans sa valise. At the time, you used to come to the hospital, you know, the day before, and he said the patient comes with his suitcase, lives with his suitcase, and not in the suitcase. He died 2 years ago, and I reflected back on that moment because to me it was a seminal moment. And I didn't realize that actually this phrase, not only have I used it a lot in teaching students and residents, but it had become kind of my guiding principle. And it probably started my interest in outcomes. Because it doesn't matter what sports cars I drive or not drive, and how good I look, how well I dress, or whether I am in the top doctors in, you know, the New York Times magazine. What matters is what the outcome is. And it doesn't matter how elegant I look when I do surgery. Besides, you wouldn't care because you're asleep. All these things don't matter. What matters is that the patient is going to leave the hospital in one piece, to use that analogy. And that's all that matters to the patient in the end. So what is excellence? And ask ourselves, you know, world class? Everybody's world class these days. You would have to claim intergalactic fame, you know, for someone to pay attention. Any little hospital anywhere, we have world class, so that's gone. You know, world class doesn't call attention anymore. Is it patient-centered? Because now everybody is patient-centered. Well, we ought to be patient-centered. Number one, you know, now we're number one. U.S. News and World Report, number one. You know, that you know, carries some weight. People look at that. So our organization is number one in New York City, has been for many years, is number 6 in the country. It does reflect something. But what does it reflect when you go to see your doctor? You know, higher level of care. And many more attributes that you see every time you hear, you know, you listen to 880 News or some other place, and everything is world class and the best in the world, and come see us. If you have a problem, we are the best. I recently gave a talk at a national meeting about metrics, you know, and I talked about metrics, because there are so many. There's publicly reported data, and there's a safety network that reports this through the Center for Medicare and Medicaid Services. There are state-reported outcomes that actually I will show you. You can go on your computer and look up how certain hospitals perform. And there's voluntary reporting, etc. So there's actually data out there that not only the professional can access, but you can. This is the Medicare website, and this is us here. We voluntarily report our outcomes. So this is surgery in patients over 65. We are better than average. Colon surgery, we are average. Actually, we're better than average, but at the time we were still average. So you can actually go on that, and certain hospitals voluntarily report their results based on their participation in a program that is sponsored by the American College of Surgeons. State reporting. So you can go on the state website or go in state infection incidents. And this is for colon surgical site infections, 2011. There's a reason why I'm showing you this. And look at our hospital that was called at the time the New York Medical Center of Queens. We're in the red, which means we're an outlier. We have worse outcomes, worse infection outcomes than anyone else. Now you have someone that's blue, that is Mount Sinai. I can tell you that the most recent one, we're the blue ones and they're the red ones. But you can access that data for any hospital, and not just for infections, but for a host of other outcomes. So, you know the data. This king says, I'm concerned about my legacy, kill the historians. So what surgeons and others will do, I'm concerned about our outcomes, kill the data. We'll discuss, you know, I don't believe the data, it's not right, it doesn't consider this and that and the other thing. The data is the data. And those who have good data will not question the data, and those who have bad data will question the data instead of saying, why do I have bad data? Why are my outcomes bad? Let's fix it. So this is me, 2012, hot, you know, in my new spot right here, the graduating class, all our faculty, everybody's smiling. This was in June, I had just come in May, this big department, I'm all excited. A few weeks later, my director of quality, who came with me from my previous employment, calls me up and says, I saw our latest report from the institution. I'm getting hives. Why? You can kind of see it. You see these lines here? They're supposed to be red. Can you see that? That it's kind of pinkish? No. This is what we call a NISCRIP report, and I will show you which ones are red. And red means you are in the bottom 10%. White means you're in the crowd. Green means you're in the top 10%. So, vascular surgery morbidity means that you can have a complication, bottom 10%. Pneumonia, bottom 10%. Return to the operating room, bottom 10%. So, the likelihood of needing surgery after you had surgery because of a complication was one of the highest in the country. Emergency surgery mortality, the likelihood of dying from emergency surgery, one of the highest. Colorectal morbidity and SSI, this is surgical site infections, one of the highest in the country, and. There was no green, a lot of red.
Which hospital was that?
Ours. Yeah.
2012.
Yes, our hospital.
That's this one over here?
Booth, yeah, Booth.
Yeah.
Booth?
But now it's no longer. Now it's New York Presbyterian. I'll show you the most recent data we have. So, why is that? I mean, you have to ask yourself, there's all these nice people sitting there, well-intentioned. There's no surgeon there that says, I'm going to hurt a patient today, or I'm going to cause a complication. So to lighten up the mood a little bit.
Every time somebody recommends a doctor, always the best. Always, is he good? Always the best. This guy's the best. They can't all be the best. There can't be this many bests. Someone's graduating at the bottom of these classes. Where are these doctors? Is somewhere someone saying to their friend, you should see my doctor. He's the worst. Oh yeah, he's the worst. He's the absolute worst there is. Whatever you've got, it'll be worse after you see him. It's just, he's a butcher. A man's a butcher. And then there's always that, make sure that you tell him that, you know me. Why? What's the difference? He's a doctor. What is he? Oh, you know Bob. Oh, okay, I'll give you the real medicine. And everybody else, I'm giving Tic Tacs.
So, it's true. We surgeons, like other doctors, have a distribution of excellent, average, and bad. It's a fact of life. I can tell you, when I go to the annual meeting of the American College of Surgeons, and you have one of those big lecture halls with thousands of surgeons, if you ask them to rate themselves between excellent, average, and not so good, someone hit an extra button asking, what is higher than excellent? Because I am. Nobody would say they're average. Nobody. But we know that is not possible. So, there's something called the Dunning-Kruger effect.
If you're very, very stupid, how can you possibly realize that you're very, very stupid? You'd have to be relatively intelligent to realize how stupid you are. There's a wonderful bit of research by a guy called David Dunning at Cornell, who's a friend of mine, I'm proud to say, who's pointed out that in order to know how good you are at something requires exactly the same skills as it does to be good at that thing in the first place, which means, and this is terribly funny, that if you're absolutely no good at something at all, then you lack exactly the skills that you need to know that you're absolutely no good at it.
This is funny, but it's true. And it's called the Dunning-Kruger effect. And actually, they observed a gentleman that started who put lemon juice on his face and went to rob banks and was surprised that he got caught because it's invisible ink, lemon juice, right? So he thought that putting lemon juice on his face, he was going to be invisible. And it's a true story. So these guys started to to actually study this, but it's a cognitive bias that, you know, an unskilled person suffers illusory superiority. So mistakenly assessing their ability to be much higher than it really is. Now what's worse when you're in surgery is to fail to adequately assess your level of competence. That goes for all physicians, but particularly for surgeons. Or their incompetence, and thus consider themselves much more competent than everyone else. So in surgery what's important is to know your limits. So in my previous employment there was a surgeon who we called a lump and bump surgeon. He was doing hernias, some breast surgery, and some other little things, maybe a gallbladder here and there. He was an outstanding surgeon. Everybody else thought he was a lesser surgeon because he didn't do the big stuff. But he never had a complication. He knew his limitations. He was excellent at what he was doing. And when there was something that required a higher level of expertise, he would send it to someone he trusted. Isn't that someone you want to go to? This guy was world class, but it wasn't perceived as that. So those of you who listen to NPR, you know Lake Wobegon, yes? So it's called the Lake Wobegon effect because, what does it say? The news from Lake Wobegon, well, all the women are strong, all the men are good looking, and all the children are above average. So that's the same. So it's the Lake Wobegon effect. Here's a quote from Mark Twain. It ain't what you don't know that gets you into trouble. It's what you know for sure that ain't so. So to be overly secure about your opinion, but how are you going to figure out that it's actually wrong? Or those of you who have seen, you know, The Big Short, the truth. And you know, that's a quote from the movie. But I love that because people don't like the truth, as we very well know these days. When faced with the truth, and we call it data, what is the reaction you're going to have? So there's an interesting paper that came out a while ago while I was doing work on the whole subject of culture and what we call the truth. And this paper looked at reports on institutional culture. There's some tests that look at culture in hospitals. And they found out that hospitals with a high level of culture had a low level of infection, which is really fascinating because it had nothing to do with giving antibiotics on time or the right surgery. It was just, when we talk about culture, it means, you know, there's all these definitions of culture. What it really is what you do when nobody is watching. Are you still doing the right thing every time, all the time for your patients? Or are you cutting corners when nobody is watching? That's what we're talking about. So all they were looking at is that. What is the institutional culture and how does it compare? And here you can see that's a graph that shows this is the rate of infection, so the higher the worse, and the culture, the higher the better. So you see this hospital down here, high culture score, no infections. And they showed that. Nothing else, which is really fascinating if you think about it. We don't talk about medicine here, only about culture. And there's a correlation between culture and outcomes. How do people feel about doing their job, and do they feel that they have a duty to do right by the patient? So we did one of those safety attitude questionnaires because I was telling myself when I saw that with all the red and the red and red, there's a fundamental problem here. This is not about something where we're giving the wrong antibiotic at the wrong time, not reliably so. There's a fundamental problem. And so these questionnaires will ask questions such as, would you want a loved one to have surgery in this hospital? Do you feel safe in your environment? Do you feel that what you're doing is appreciated? Do you feel comfortable calling attention to a problem without fear of repercussion? And. Very subtle questions that kind of circle the fundamental question that is it safe to have surgery there? And that is a question that is not asked by patients, but is asked to all the staff. So the surgeons, the residents, the nurses, the techs in the OR, etc. I'll spare you the result, but it was horrendous, as it usually is when you do that for the first time. So we had the result of the culture, and the usual quote you hear is, changing the culture in an institution, and that could be a business of any kind, not just medicine, is like turning an aircraft carrier. Has anyone ever heard that? Like impossible?
Very slowly.
Aircraft carriers can actually turn on a dime. You can go on YouTube, and this is actually one doing so, because they have engines that can push them sideways. And it's actually quite amazing, and they stand there, and the aircraft carrier is actually about 30 degrees like this, and they turn around. So it is possible. The difference is that the captain has to say, we're turning now, some other guy's pushing buttons, and everyone else is just going along with it. When you want to change the culture, you have to convince everyone that it's the right thing to do. You can never force them to do it. Because if you force them to do it, which in my position I could, it'll be short-lived and resented. So you have to call on their duty to do right by the patient and to keep patients safe. So you keep it at that level, because that's our very basic relationship with the patient. So what happens with the culture here? Imagine every arrow is a surgeon, a nurse, someone involved in the delivery of care of my patient. And everybody in their mind believes that they're doing the right thing. And I emphasize in their mind. The problem is that they're all doing something different. Because in their mind they're doing the right thing. But as a group they haven't agreed on what is the right thing to do. So just imagine those are all little metal arrows, and what you want to do is have a magnet that will pull them all in the same direction. Does that make sense? So you do the magnet and they all turn around. So what is the magnet? The magnet is patient safety, very easy. Now if you're in a big financial firm, something else, it could be you get no bonus, and that's the magnet. But if you think about it, how stronger of a motivation can there be for us as patient safety? Because why did we get into this business in the first place? And then you do it, and everybody does this. Now this has two advantages. You have to talk and agree on what is the right way of doing something based on research, papers, opinions. You have to come to consensus to the group. The group will decide what is the right thing to do. And then you have them all aligned. So you set new standards. You say, we all agree that we're going to do it that way. The advantage is then you have set clear and explicit expectations. And if someone doesn't do it, you can sanction them, because the group has agreed that it's the right thing to do. You can't do it the other one, because everybody does their own thing. And no one has ever said, this is the right way to do it. And then you do it over and over again, because things change. So if we all feel like, wait a second, there's been a new paper describing doing it that way as opposed to this way, let's sit together, discuss it. And then we all agree that we'll change, we'll write a policy, we'll tell everyone, and now everybody knows. So changing culture cannot be this way. So those who can't read it, it says, so does anyone else feel that their needs aren't being met? You know, you just push them off the cliff. Well, you know what's going to happen if you do this? As soon as this guy turns his back, they're going to push him down. And that is what I meant when you force people to do something as opposed to agreeing to do it. I'll skip this one. So how did we do? we did big interventions. We got 300 people into a room and educated them as to the science of safety. There is a science of safety, airplanes and many other places, where you predict where the mistake is going to happen and how to avoid the mistake. Where you agree what is the lowest acceptable level of safety and make sure through processes and checklists and other things that everybody is going to do it that way. And you empower people to be part of that process. So, these are the data points that we get, and they're called teamwork and are we afraid and so forth. This was the first one we did, the second one, the third. So over the course of 36 months, our scores statistically improved. Okay, people participate and all that. What does it mean really? Well, this is our colon infection rate. When you had asked, is this the hospital here with the red? Yeah, that was here. So we had an infection rate of 17%. It went down to 12, 10, 12, 10, 3, 3, 3. We put a lot of work in here during this time. So we went from needs improvement, the red, remember, red is bad, white is okay. Over the course of 2 years now, we have maintained our position in the top 10% of over 800 hospitals in the United States. By having people care and not accepting substandard outcomes. So lower people's tolerance for that. And having an aspirational goal of a no complication, no death environment. Now we all know that doesn't happen. But from an aspirational point of view, we should have that. So whenever we have an infection, we should ask ourselves, we do ask ourselves, have we done everything possible to mitigate the risk of that infection or heart attack, whatever that can be? And we look at the case, and if we have done anything, we accept the fact that it is not a zero infection environment, that there will be a few. 3% or 3.5% is very, very, very low for colon surgery. But still, we'd like to be lower. So we have another initiative now looking at that. Now, this is a graph, and I'll talk you through it. This is an odds ratio. What is an odds ratio? An odds ratio predicts an event from happening based on a prediction. So, an odds ratio of 1 means that the computer in the risk model predicted that someone should not have an infection, and in fact they did not have an infection. So that's 1. Or the computer predicted that based on risks, because it was emergency surgery, there was a hole in the bowel, they should get an infection, and in fact they get 1. If your odds ratio is higher than 1, you're doing worse, because you're having more infections or other complications than the computer predicted. If your odds ratio is less than 1, then you're doing better. So having an odds ratio of 1 is like, okay, we did the way we should. Big deal. If you have an odds ratio less than 1, you're doing better. So remember, red is bad, white is okay, green is better. This is over the course of 3 years here. And you can see we started out with a lot of red and only 1 green. And as you go along, there's only 1 red left, a lot of green, and the overall odds ratio, you can see here, has gone down. Only by doing that culture intervention. And we did another few things. But just making people, setting expectations, what should patients expect from us? What we would expect if we were patients. And so in the whole environment here, we're actually writing this paper and we present it at national meetings. No one has done that before. That paper I showed you before found a correlation from hospitals that reported their outcomes, but no one has actually done that and sustained You see, you don't want to just say, hey, look at me, I'm so good, we fixed the problem. Well, how is it going to be 2 years from now? So this is really important. This is just another one where you see the proportions between red, white, and green. I presented this to the chief of surgery at Cornell, which is a friend of mine who's Italian. He said, great, got the Italian flag here. But you see, we used to have 40% red and only 4% green, and now we're at 9% red and 35% green. And truly, this is probably a statistical error. We actually don't have a red there. But it's okay to have red if you come up with a plan to fix it and fess up to it. So what makes a good surgeon? Well, what makes good surgery? You know, oh, I have this, my neighbor said I should go to this guy, he's the best, you know, the Seinfeld thing. And you've all heard that. And the family, then you go to Sloan, you go to this, you go to that. I can tell you right now, I trained at Sloan Kettering. Not all the surgeons at Sloan Kettering are top. Not all the surgeons at Queens are top. But you want to know in aggregate, does the place care? And are they keeping track of outcomes to be sure that their patients are being given the best care possible? So this is the values of the American College of Surgeons, and their professionalism, exemplify the highest standards of accountability, honesty. You know, when a patient asks me, well, how many of those do you do a year? Get this all the time. I said, you're asking the wrong question. How do my patients do? I could do 100 and they're not doing well. So I'm doing 100. Great. I said, you'll always find someone who's doing more than I do. But how many patients have died from these big pancreatic surgeries I've done? And I can tell them in the last 5 years I've been here, none. You know, want to talk to one of my patients? I have patients who readily, you know, will talk to one of my patients. So honesty, responsibility, loyalty, and respect, that creates an environment that strives to do right by the patients. Excellence, we aspire to excellence. Innovation, sure. But you know, innovation, particularly in New York and other big cities like that, people do what I call stunts. They will do a robotic this and that, they're going to be on ABC News, and what does it do for anybody? But then they get all the referrals because he's the guy that's been on TV and does all this stuff that, by the way, should have never been done in the first place, and years later everybody actually knows that. Introspection. Seek continuous self-improvement through self-awareness, self-assessment, and professional development. So critical. How am I doing? How do I know? I'm actually asking people to tell me. Which is really important because otherwise you're in that illusion, believing that you are world class, and you're not. And inclusion, you know, include everybody. And that's a long list of things. To me, in those terms, it's go for green. I want to work in a place that is not happy to be in the white, that is aiming for that green dot there. I would want to be taken care of by someone who aims for that. And not for the sake of being a hotshot. No, because I want to be able to tell a patient, which I can now in the office, if you have colon surgery there or pancreatic surgery with me, your likelihood of dying from this and your likelihood of having a bad complication and an infection is one of the lowest in the country. And I can tell that honestly, based on data, not just because, you know, I am in that institution that just claims to be the best in the world and I'm just going to throw that out there. You have to have that honesty. And so, slowly but surely, the medical community is realizing how important this is. And how not important all that other stuff is, that glow, that shine, that may actually not be really good. Thank you very much. I appreciate your attention.